Recording in progress. Good morning, Bianco. How are you this morning?
I'm doing great. How are you, Dr. Mulder?
I'm doing fine. Hey, I just wanted to let you know, I listened through your lecture from last week and I thought it was terrific. I thought you did a fantastic job with that. We've never had that subject broached before, and I just thought it was fascinating and very, very well done. I just wanted you to know that.
Thank you so much, sir. I mean, yeah, it was really interesting topic.
I'm sure it was fascinating to explore that.
Mhm.
And so, and I've also got you on for the case presentation later today, this morning?
Yes, sir.
Okay, great.
Yep.
I'll go ahead and make sure you've got privileges for that and we'll be good to go.
Thank you. When you are giving me the privilege later, Dr. Mulder, could you give it to Byung-Cho Kim instead of the Byung-Cho Kim CH?
Okay, doke, I'm doing that right now. So
Oh, thank you.
that's what I got. All right, cool.
Thank you.
Good morning, Allie.
Good morning. How you doing?
I'm doing fine. And so you're on deck today, huh?
Yep.
Wonderful. Looking forward to it. Let me just give you the hosting privileges so that,
Thank
hang on a second here. Make sure that you've got, what you need.
All right. I'm going to try to share presenter mode. So I'm hoping that you guys will just see, ultimately, once I pull it up, that you guys will just see my slides.
See your notes too.
You do? Okay.
Yeah.
Shoot.
Which is, I don't think it's a huge problem. It's small print from where we are, so we're only going to be able to actually see the slides. The others just off in the margins.
Okay. I made a printout like that I'm hoping I can get.
Yeah, even the other thing, just to, and if you're using slides, it's probably not that big a deal, but you have a beam of light coming smack down through the middle of your screen.
Oh, shoot. Okay. Let me hang on one second.
So,
Okay. Can you see me at all now? Let me see.
I can, looks great. Yeah,
Okay.
it's a really wonderful moody sort of a thing. You got nice glow on your face coming off your computer screen, and so yeah, no, I think it
I can
looks
turn
great.
the light back on. I closed the blinds. I don't know if it's the blinds or the light.
It was the blinds. If you just close the blinds, that's what
Okay,
it was.
let me turn the light back.
Nope, it was a light.
It was the light, seriously?
It turns out that it's a light. Yeah.
Oh my gosh. Sorry. Oh,
I'm not sure where your blinds are, but yeah, you could probably do those, but you look fine. It's just in the dark.
How's that?
Oh, that's perfect. Yeah, that's
Okay,
even
great.
better.
Great. Oh, shoot. I was hoping this would load by now. Sorry, I'm gonna give it one more chance to see if it'll load. Can you shut the door? Yeah. No, I'm good. I know. Ah, shoot. Okay. I mean, if you guys are okay with presenter view, I can go ahead and get started. Can you guys hear me?
Yeah, I think it's fine from my perspective.
Okay. Sorry, I don't like to do that, but all of my backup methods have failed, so.
I think it's whatever works for you.
Okay. And then maybe if it loads, I'll switch back to regular view.
Okay, just before you get started, I just wanted to let the audience know that this is the last lecture of our 23-24 lecture series. We do not have lectures on the 20th and the 27th this season. So we will start up again on July 11th. Obviously not going to do it on the holiday from the 4th. And then we will planning on using the same link that we have been using, that we don't have to change that. So we'll continue to use that for the and you'll still get the weekly notices from Susan, so that will be in there as well. But if you have a bookmark, you should still be able to use it. For the CME, hopefully that's been working okay for you. Just kind of a minor just logistic thing. When you put your name and email address in the chat box, make sure that you put your name and your email address. Some of you just put the email address, and I got to kind of guess what your name is. I hope I'm getting it right. What I don't know for a lot of you is what your title is. So it's got to have the title as well. MD, DO, MP, whatever that might be. Make sure you get your full name and the title and your email address. And that helps to smooth and facilitate the logging for our CMEs. So that's it. So for one of your last official functions as a fellow, Dr. Ortiz, you may get going.
Alrighty, so my lecture today is going to be about treatment of mental health conditions in hospice and palliative care settings. I know that's a really broad topic, so I just wanted to kind of primarily focus on anxiety and depression, as well as a little bit on grief. And then I really wanted to focus on non-pharmacologic treatments. So I'll get into that in a little bit. But first, here's my objectives. And I apologize, my slides are a little bit wordy, but I really wanted this to be a good reference for you guys moving forward. So here's kind of why this is important. So this is just a graph of the prevalence of any mental illness in US adults. I was really shocked. The overall percentage is 22.8% of the population. That's age 18 or older. So that's not even including adolescents with depression or anxiety or any mental illness. It's higher among females, which isn't really terribly surprising, considering that anxiety tends to have a higher prevalence in women. And then it was higher in young adults, certainly much higher in young adults than it was in older adults. And then interestingly too, any folks with 2 or more declared races ended up having the much higher percentage. So just some interesting kind of stats to start this off. So why is this important for us in particular as hospice and palliative medicine providers? So there's a lot of facts here, but essentially the overarching theme is that folks that have depression that is comorbid with a chronic life-limiting illness tend to do worse overall. So they have longer hospital stays, they have reduced quality of life, they have higher risk for attempted or completed suicide. They have much higher rates of death requests through physician-assisted death or anything like that. There's been a higher symptom burden reported for patients with cancer. And then anyone with depression that gets admitted to a nursing home has a higher likelihood of death within the first year of admission. So I briefly want to touch on some diagnostic tools. So these are straight from the DSM. So I wanted you guys to have the exact reference for the diagnosis. I'm not going to read all of this to you. What I want to point out is that for depression, basically the biggest criteria that they need to fulfill in order to make the diagnosis is any of these, there's actually 9 of them, those numbered bullet points. And if you kind of remember, like all the way back to medical school, that's your SIGI CAPS mnemonic. So kind of depressed mood, diminished interest, weight loss or gain, insomnia, like agitation or retardation, like slowing down a lot or getting really like moving very fast. And then, your fatigue, feelings of worthlessness, diminished ability to concentrate, and then recurrent thoughts of death or suicide. So essentially, you need to have 5 out of those 9 in order to kind of meet the criteria to be diagnosed with depression. And then the time period for depression is a 2-week period. So that's kind of different than some other psychiatric disorders where it's a longer time period that's required for diagnosis. So depression is a 2-week period. So those are the major criteria, and then you've got other minor criteria. So A through C, basically, if the patient meets the criteria for A through C, that represents a depressive episode. And then there's a note here too, that if a patient is grieving, that we need to take that into consideration when making the diagnosis, and perhaps they meet criteria for prolonged grief disorder instead of major depressive disorder. I know there's a lot of symptoms that are listed under the diagnostic criteria that overlap a lot with what we see in our patients with chronic disease. And I'll get into that in a little bit about how to kind of keep that in mind when you're trying to diagnose people. Is this an episode of major depressive disorder, or is this actually just disease progression? So for depression, there's some risk factors and prognostic factors. So this is also from the DSM. So you have temperamental risk factors. I thought this was really interesting. I had never really read into this before, but there's a personality trait called neuroticism, which if you think like the kind of colloquial use for that word, it kind of fits with the medical definition as well. So people that are very just kind of like obsessive and like kind of rigid in their thinking, people that kind of, when something stressful happens to them, they kind of spiral out. So that's kind of a trait that's been linked to depression. And interestingly, kind of skipping ahead a little bit, to genetic risk factors, it's thought that this neuroticism is a heritable trait, kind of explains the heritability of some mental health disorders like anxiety and depression. So I thought that was interesting. And then environmental risk factors, certainly adverse childhood events. Glad to see that they're getting more kind of attention from the medical community as pretty significant risk factors for a lot of conditions, including mental health conditions. And then if depression is comorbid with another chronic physical or mental health condition, it's usually more refractory to treatment. So obviously our patients are going to have a lot of comorbid conditions. So you might find that in our patient populations, their mental illness is more difficult to treat than it would be if we were just trying to treat the mental health condition. All right, so moving on to anxiety. Again, this is straight from the DSM. I don't have acute mnemonic for anxiety, but I do want to point out the biggest thing that's different about the diagnostic criteria is that anxiety requires at least 6 months of ongoing symptoms, and it must kind of impact the person's day-to-day life. So this isn't just like, oh, I'm worried about this lecture I had to give today. It's like, I'm worried about every single little detail of things. So the symptoms are listed kind of in the bullet points there, kind of that restlessness, or just kind of like moving like all the time, difficulty concentrating, irritability, muscle tension is a big one. I see that a lot. There's a lot of like somatic symptoms that can present as anxiety, or anxiety can present as. And then sleep disturbances as well. That's pretty typical. Just a couple more like bullet points here. I do want to point out a lot of people are kind of unsure about what really is the biggest difference between just somebody being afraid of something. So what is the difference kind of between fear and that kind of excessive worry that we consider anxiety? So fear is more of an emotional response to either a real or perceived threat, and anxiety is like the anticipation of that threat. So fear is kind of more, you see something and, you see, I don't know, a lion and you're afraid. But anxiety is like you go to the zoo and you're worried that you're going to see a lion. So like I said, anxiety really commonly presents with somatic symptoms. There's a list there that's pretty extensive. I will say that muscle aches, pains, tension, those are very common presentations. And then a lot of folks have a lot of GI symptoms, diarrhea, nausea, super, super common. Even people that have, sort of performance related anxiety, they'll get like a GI response prior to a big event. Again, some risk and prognostic factors. There's some kind of traits here, behavioral inhibition, neuroticism, and harm avoidance that have been associated with developing generalized anxiety disorder. And then environmental factors. I thought this was interesting. So again, adverse childhood events, not surprising there. But parental overprotection. There wasn't really an explanation in the DSM as to why that might be the case, but I thought that was really interesting. And then the genetic kind of heritability patterns follow similar patterns to depressive disorders. Again, likely because of that heritable trait of neuroticism being passed down. So when we're diagnosing, I said that depression and anxiety here, but really any mental health condition, we have to keep in mind that it has to bother the person. It has to really cause distress or dysfunction. And then when we're diagnosing a primary psychiatric disorder, you have to rule out everything else. Vitamin deficiencies, electrolyte disturbances, substance use, neurologic conditions, they all have to be ruled out because psychiatric disorders are a diagnosis of exclusion. There's been some specific disease-related associations. I'll let you guys read those there. And then I do want to point out mass depression. So this is very common. So depression or anxiety symptoms manifesting primarily as physical complaints. The biggest one really is going to be either fatigue or insomnia or both. So keep that in mind when you see a patient that's kind of complaining of a lot of generalized somatic symptoms. Might be worth giving a screening test. So, there's a lot of conditions that we see in palliative care that present with a lot of those symptoms that we saw on the DSM criteria. So it's interesting because conditions like hypothyroidism, you would expect to see fatigue and appetite changes. Doesn't mean they're depressed, it means they have hypothyroidism. And that's why it's important to kind of run your battery of testing because those symptoms would improve with just levothyroxine in somebody that has hypothyroidism. So the biggest question is, so how do we know if patients with these actual diseases that we're seeing, cancer, COPD, heart failure, how do we know when they're actually experiencing a comorbid mental health condition? There's not a lot of good scientific evidence to show that one specific symptom is linked more to mental health conditions and folks with chronic illness. There's a lot of sort of anecdotal evidence. So demoralization was one that was kind of pointed out a few different times. So that kind of feelings of despair, helplessness, hopelessness, that was linked fairly commonly to folks with comorbid depression or anxiety. But really often, the approach that we use is just to stick to the DSM criteria, accepting the risk that you might be overdiagnosing patients. But it's better to, at least in my opinion, it's better to overdiagnose and potentially overtreat than it is to undertreat folks who are struggling with, depression or anxiety as they near the end of life. So that's kind of my thought process on it. You guys might develop other practice patterns. I wanted to give you kind of the whole explanation or the whole breadth of different ways people diagnose things. So I have a couple scales. You're probably familiar with the PHQ-9 and GAD-7. So PHQ-9 is for depression, GAD-7 is for anxiety. Those are based directly out of the DSM. So those are literally just the DSM criteria in a way that people can understand. So this is another one I wanted to point out. Again, I'm not going to read through this, but I wanted to give it to you as a reference. And then this one is one that was pretty commonly used in a lot of the studies I was reading because it screens for both anxiety and depression. And it's designed to be used in people that are in the hospital. Brief word on prolonged grief disorder or complicated grief. So prolonged grief disorder is sort of the DSM diagnosis. It was added to the DSM in 2022. So that was with the revised version of DSM-5. So that's a pervasive grief that continues for more than 12 months after somebody dies. So those are kind of some symptoms there. And then biggest important thing too is it can coexist with major depressive disorder if the criteria for both diagnoses are met. There's a screening tool that I'm going to show you guys, and then this assessment tool from the National Palliative Care Research Center is really good. Excuse me. So that's an assessment tool for both diagnosis and determining the severity of someone's prolonged or complicated grief. So that's a really good reference for you too. This is the brief grief questionnaire. There's a lot of different screening tools out there. When I was shadowing a social worker with our hospice organization, he had a very brief version of this that he was giving prior to the death of someone. So I don't have a copy of that one, but I think it's good to know that there's a lot of screening going on for complicated or prolonged grief. So speaking of social worker, I want to spend the majority of this talking about how our multidisciplinary team can help support us as providers when we're treating folks with mental health conditions. So a couple like little things I wanted to point out. I found this like ABCDs of caring in one of the articles I read, and I just really loved it. It really resonated with me. So anytime that you're going into a patient encounter, making sure that you're aware of your attitude, behavior, compassion, and dialogue. And then involving our interdisciplinary team members, social workers obviously are going to be essential team members here. And then psychologists, some teams have them, it's pretty cool. Or if they're available by referral, that can be an invaluable resource as well. And then any team member providing active, attentive listening can be beneficial in the treatment of these conditions. So I'm going to talk a lot about different kinds of counseling. So there's different structures to counseling, and then there's different types of counseling. So this is sort of like who is actually present. So individual counseling, again, any of these really can be performed by a psychologist or social worker. And the goal of individual counseling really is to help people develop positive coping strategies to overcome stressors. So people can undergo therapy as couples or as families. And dignity therapy is an example of family counseling that I will show you guys. And then there's also family support groups if you think like your kind of cancer support groups. And basically what those support groups do is they can help people express feelings of avoidance, denial, feelings of hopelessness, helplessness, alienation, basically providing a safe space where people can kind of talk about how they're feeling to people who are experiencing a similar problem. So cognitive behavioral therapy is probably what you think of when you think of therapy. It's the most common used form of therapy. It's used mostly for anxiety and depression, which are very common. So it's based on several core principles, basically having a lot to do with unhelpful ways of thinking and unhelpful behavior, trying to sort of train your brain to change thinking and behavior patterns to basically sort of retrain yourself to get away from that unhelpful thinking and unhelpful behavior. So a few things that will happen in cognitive behavioral therapy is you kind of learn to recognize like some distorted ways of thinking and how you approach problems, and then how to reevaluate that thinking pattern. You gain a better understanding of behaviors and motivations of others, and then learning to develop greater confidence. So those are kind of ways that CBT can help change thinking, but it also can help to change behavior. So kind of facing fears instead of avoiding them or denying them. Learning to kind of calm down, listen to your body, relax before you go into certain situations, and then preparing you for potentially problematic interactions with others. So kind of having a game plan before going into a situation. So I want to spend some time on dignity therapy. So we all kind of talk about dignity and dying with dignity. Those are some definitions there. But dignity therapy in particular is a type of therapy where it's a family that's sort of doing this together, although the patient is the one who primarily is completing an interview. So what it is it's folks that create a legacy document, whether that's recorded or written, either or. But the goal of it is to capture the individual's life story and then hopes for the future as well. So this is a practice that's relatively commonly done informally, but it's nice to see there's quite a bit of evidence for it actually being helpful. So it can reduce suffering burden, confer a sense of peace, and it can demonstrate a protective effect against further deterioration. So there's a study that I actually looked at where I'm going to show you some graphs in a second, but essentially they reflected on the person's life story, their achievements, some of the roles they played in life, wishes that they had for their families, and anything else that they really wanted to be remembered. And these were structured interviews over the course of 3 separate occasions that were recorded. And then they were able to be shared with the family after the patient's death. So that proved to be very beneficial. So I have some graphs. Oh no. So I have some graphs here basically showing that most people at least found it somewhat helpful. And there's not like a risk to completing it. So it's just a really nice tool that we have that can be relatively easy for us to kind of explain to patients and families, and they can complete on their own time, essentially. So most of the people that were participants in this study actually reported improvements in emotional and spiritual well-being, as well as kind of level of suffering. So I think it's really cool. I think it's a really nice tool in our toolkit. And I think, it's something that we can keep in mind. I want to point out an example, and I actually have the booklet. I don't know if you guys can see it, but it's a little booklet from Centrica, which is our hospice organization, and they call their program Story Catcher. But when I was actually preparing this lecture, and then I was working with the social worker, and I was like, oh my gosh, that's dignity therapy. So basically how Centrica does it is they give the patients a little booklet, and it has all these questions in it. And it actually has it has more questions. I didn't want to put a bunch of pictures in there, but, and then it also has reminders of different decades so that you can kind of prompt conversation. So they also will do an audio recording, and that will be provided to the families. That is actually fairly popular with Centrica and their patients, to the point where they used to only provide the recording after the patient died, but they've had a lot of requests to provide the recording kind of as soon as it's ready. And that can be kind of shared and given to other family members and friends. It's something that they put in like a secure website so that anybody that has a link can listen to it. So I just think that's really cool, and something to kind of look into to see if maybe your organization has something similar. All right, so there's a few other types of therapy I wanted to briefly touch on. So meaning-centered psychotherapy it's basically a type of therapy that is particular to patients that are kind of suffering from that loss of meaning, that loss of roles. And we see all the time patients that don't want to be a burden, or that don't want to rely on other people. They've been independent their whole lives. So they sort of lost that meaning or that feeling of independence. So this type of therapy can really help people focus on the importance of kind of creating new meaning or experiencing new things in life, even in the face of a chronic illness. Acceptance and commitment therapy is a specific form of cognitive behavioral therapy. Basically, it's using several different techniques, most importantly, just trying to accept the things around you to improve mental health and well-being. So that's, again, it's targeting those sort of behaviors, like being present, finding acceptance, taking perspective, those sorts of things. And then insight-oriented therapy is, it's pretty different from cognitive behavioral therapy. So basically, this form is more of an introspection. So it's a form of psychotherapy that basically postulates that the patient's problems can't be resolved until they gain self-understanding. So it's a lot of introspection, a lot of psychoanalysis, a lot of basically just kind of talking and not a lot of behavioral or thinking modification. All right, so a brief note on spiritual needs. So our spiritual care team members really assist patients with a lot of different things. I think it's really interesting how our chaplain colleagues can kind of work on some of this, like seeking the meaning of life and obtaining emotional support, alleviating fear of death, some of these like really big concepts that they can really they feel comfortable talking about, and they can help people achieve sort of an understanding and a peace around those issues, and not even in a religious context. If the person is not religious, there are other ways that our spiritual care colleagues can kind of get into those details. Obviously, we know that spiritual health plays an important role in coping with, psychological symptoms, but also physical symptoms, I would say. And then spiritual care in general has been shown to improve cancer-related fatigue. And then this is, I read a study that was really interesting. So regular religious practices, if they're already established, it's not necessarily something that is going to help if a patient's getting into it for the first time. But they have been associated with fewer depressive symptoms and less suicidal ideation. So I actually found a study that looked at Islamic religious practices. And basically, they were found to be associated with fewer depressive symptoms, less suicidal ideation, overall improved satisfaction in patients that lived in Saudi Arabia. All right, so I want to encourage you guys to always be thinking outside the box. So things like exercise, as tolerated, I think can be really beneficial. I always like to recommend stuff like just going to the pool and walking, or recumbent bike, something that's not going to be too physically hard on the body, but can be really beneficial in terms of emotional health. Again, it's kind of getting back to that losing independence, and definitely can help reduce fatigue as well. There's some other really interesting things like mobile apps. I have some screenshots I'll show you from that app, Aya. And then herbal therapies. I don't want to get too into them just because the evidence is really lacking, but these might be things that that people are using. And as long as they're not ingesting, so things like lavender, people will use that a lot of the time as like aromatherapy. I think that's totally fine. Where I get a little iffy is when people ingest it. So anything that is a pill that they're taking. I just would want to make sure that you guys are encouraging good communication so that you can know like if there's a potential interaction with any other medications. So like black cohosh, people use it for breast cancer, like for the hot flashes, but it's hepatotoxic. So, I wouldn't want somebody to take that and Tylenol and Percocet. We just got to be careful. All right, so here's some screenshots from that app. This is one that is actually studied pretty vigorously. I think it's really cool. They have like a social media component to help meet other folks with the same. It's specifically for adolescents with cancer, but I don't see why you couldn't use it for other life-altering diseases. So you can kind of make a profile, chat with people who connect with you. They have different like virtual events, which I think is pretty cool. And then they have also different coping strategies and different like almost like little therapies within the app itself. So I think that's really cool. I did not see if it was paid or free though. I can look into that if you guys are interested. But this one is studied and it's validated. All right, so I do want to spend some time talking about some basic pharmacotherapy and some of the basic concepts that we have to keep in mind when we're treating anxiety and depression. So I briefly want to talk about serotonin. There's the chemical structure because I love it. So basically, serotonin is it's involved in just about every organ system. And it's involved in just about every emotion that you can think of. So there's kind of a list there. And then the important thing to keep in mind with serotonin is it has a multitude of different receptors. So basically, when we're talking about different serotonin receptors, you have them in the brain that modulate sort of anxiety and anxious behaviors. But then, excuse me, you also have the same receptors that reward or that regulate reward processing, locomotion, appetite, energy balance. That's why a lot of these sort of different areas or different symptoms in different organ systems we see are affected by anxiety or depression. This is another list of effects of serotonin on the body. So it's really, really expansive. I'm not going to go through all of these again, but I just thought it was really interesting. I mean, even to like helping facilitate platelet aggregation. I think that's really interesting. So I want to briefly talk about the history and mechanism of action of SSRIs. So there was this link between serotonin and depression that was first introduced in the 60s, sort of gained more traction with the introduction of SSRIs in the 80s and 90s. There have been a ton of studies and a ton of meta-analyses that have attempted to prove evidence for the theory, the serotonin theory, but there's really still to date no substantial link other than the relative efficacy of SSRIs, which is interesting because SSRIs, as we know, take about 4 to 6 weeks to become completely effective. But there have been studies that show that serotonin levels actually rise within hours of a dose of an SSRI. So interesting that they take so long to work, yet they really work immediately. So what that kind of tells us is that these increased serotonin levels ultimately have other effects downstream that influence the symptoms. So, essentially, we know like what they do in the body, but we don't really understand how or why they work for depression or anxiety. So I had to include kind of a little mnemonic, shout out to first aid. So essentially, this kind of demonstrates the mechanism of action of SSRIs and SNRIs. And I like this one too because it includes TCAs and trazodone and mirtazapine and some other ones. But as you can kind of see here, so this is your serotonergic neuron. And it's producing serotonin. And then SSRIs, as we know, block the reuptake of serotonin, leading to increased amount available in the synaptic cleft. So I made these charts a while ago. I'm not going to spend a ton of time on these. I really wanted you guys to have this as a reference. So what these tables do, there's another one on the next slide. It's giving you the drug, the trade name, the class, what the palliative care indications would be for that drug, how to start, how to start the dose, how to titrate, and then a max dose, and then side effects with kind of percentages, as well as things to look out for like QT prolongation in most of the SSRIs. And then any just comments. So most of the comments are about dosing in renal failure and hepatic failure, and then how expensive they are. So I really wanted you guys to have a good reference. I didn't include some of the newer drugs because we typically just don't use them because of cost. But yeah. And then something else to keep in mind is you might see higher doses than this. This is sort of erring on the conservative end, and I've seen doses significantly higher than what I have listed. So I would recommend maybe if you're thinking about increasing more than that to maybe talk to a psychiatrist. But other than that, these are safe dose ranges for sure for us to be writing. Here's just another slide. The first slide was mostly SSRIs. This one is kind of those other like weirder classes. So like bupropion is a dopamine norepinephrine reuptake inhibitor. And then mirtazapine has like very weird mechanism of action where it's actually an alpha-2 antagonist, but then it also antagonizes multiple serotonin receptors. So kind of an interesting mechanism of action there. All right, I want to briefly touch on our treatment options when we have a very brief prognosis. So we've kind of, I think we've all heard about using psychostimulants really near the end of life for managing depression. They're used commonly at pretty low doses, and they can promote sort of the opposite symptoms of depression. So you're not necessarily getting at the root and treating their depression, but what you're doing is sort of attempting to treat the symptoms. So they can promote that sense of well-being, they can decrease fatigue, obviously stimulate appetite. And then I didn't know this, they can actually potentiate the analgesic effects of opioids and decrease opioid-induced sedation. That makes sense. So really the goal of this treatment is just to reduce the symptoms. Reducing emotional stress and then improving morale, coping ability, self-esteem, sense of control, things like that. Some dosing. So I didn't really want to get into a ton of detail because I don't think we run into this scenario very often. But methylphenidate is the one that's most studied for depression at end of life. And then these are pretty low doses. So starting at 2.5 to 5 milligrams a day, titrating up from there. Usually it works within the first 1 to 3 days. And then it's recommended that you dose them in the morning, and then at noon if you need another dose, to avoid that insomnia side effect. A brief note in peds patients. So I'm pretty sure you guys are all familiar that SSRIs have a black box warning for pediatric patients. So this is sort of a use caution situation. So you can use SSRIs in patients 6 to 18. Those are the FDA approved indications. Fluoxetine is only preferred because it has the largest evidence base. I couldn't really find any other explanation as to why fluoxetine was the preferred drug of choice, but and then there should be counseling about the black box warning, and that actually is extended through age 24. So that's something that if you're treating a pediatric patient, the parents, and if the patient's old enough, the patient should be aware of, is the black box warning for suicidal thinking and behavior. Other medications, SSRIs, bupropion, mirtazapine, they haven't undergone the rigorous testing in peds patients that the SSRIs have. So they should be reserved again for when SSRIs are not effective, or you're worried about interactions or side effects with SSRIs. And then first line therapy really should include non-pharmacological strategies like CBT. There's the most evidence for the two, so medications and therapy together being the most effective. And then here's a kind of a dosing strategy. I'm not as familiar with pediatric dosing, so I borrowed this from an article, but as you can see, it's kind of lower dosing than I would expect to see in adult patients, especially sertraline. So yeah, 25 milligrams. I don't think I'd ever start anybody on 25 milligrams, or at least an adult. So, all right. Anybody have questions?
I got a lot of them. Thanks for this, Ally. This is really, really good. And a great summary. I want to just, first of all, appreciate your focusing up front and reminding us about the importance of non-pharmacologic therapy. It was really interesting. I did my residency talk on depression 41 or 42 years ago, a very, very long time ago, when the only pharmacologic agents we had were tricyclic antidepressants, monoamine oxidase inhibitors, and antipsychotics. And that's what we had medically. And so I was around when the SSRIs hit the market. They were very, very exciting, and everything on your list on those two tables there relative to the all these drugs available. I remember when they came on the market and the excitement that they generated, and then the disappointment as a clinician with how infrequently they really produce the meaningful outcomes that we had hoped. We still live in a fix-it society. You identify something that's broken and you fix it, and you want a quick fix. Patients want a quick fix, and so you write a prescription and hope that they get better. And so often when speaking with depression and anxiety, they don't. The first question that I have for you, and then I'll shut up for a little bit to see what other people have, but I've got a list of them here that I really think would be fun to explore. And since we have time, I think we'll do that. The first thing is you noted right at the very outset the significant frequency or incidence of anxiety in the general population. So the first question is, in your reading and your research, are you able to determine why? Why are we seeing so much more now than we did 10 years ago, 20 years ago, 40 years ago?
You know, I couldn't find any really good explanation, and I was really looking for one too. I read a lot of papers from like 2023, that just kind of glossed over it. Nobody really wants to get at the root of why. So I don't have a good answer for you other than that I share your frustration and not knowing why.
So guess, postulate, estimate. Tell us what you suspect might be. And I won't put you on the hook for that because we've got a number of fellows on the line here that are young in their training. And I would love to hear what y'all's opinions are as to why we're seeing increase in anxiety. I don't have the answer, obviously, because it doesn't exist in the literature, but there's a lot of suspicions as to why we might be seeing that now. So I'd be curious to your comments.
I mean,
on
I can certainly take a stab at it.
Go for it.
Yeah, so one thing that I read a lot in the DSM was that heritable trait of neuroticism. And I don't think that it's necessarily all explained by a heritable trait. I think we've seen a increase in like distrust and mistrust in our society, and I think that's kind of the same sort of feeling of like when you have that trait of neuroticism and you're sort of like not trusting and like very meticulous and very like guarded. I think that's kind of how a lot of people's thinking has shifted in society, because of this kind of pervasive mistrust. So instead of being like a heritable neuroticism, it's more of like a societally inherited neuroticism. I don't know if that makes sense, but that's kind of what I'm thinking.
Learned behavior.
Yeah, yeah.
Other thoughts as to what might be contributing to that?
Someone just put in the chat exactly what I was going to say, which is the idea of all of our technological advances and access to platforms with social media. Like they have allowed us access to the entire world, but in the same sense, we are now taking on the burdens of happenings of people in a community much larger than what I think we were ever meant to. All of the difficult news that we're now having to process and listen to and share. I think that accelerated by the pandemic was the use of social media, that there's a lot of movements in parent circles for delaying the access to social media and individual smartphones or personal devices until much later, to help prevent some of these results that we're seeing.
Yeah, I mean, we certainly see that. You know, my wife is an elementary school teacher, special ed, and she sees, you know, you talk about anxiety in the adult population, it's exploding in elementary schools. And part of that, you know, as she looks at it, has to do with that data and information overload, which results in different expectations about what people should be doing or knowing that they don't have the capability of doing or knowing. And then there's that, you know, the fear of missing out. If I'm not keeping up to date, what am I going to miss out on? And that creates a tremendous amount of anxiety. And so that's, you know, a very non-scientific, you know, approach to that. So.
Well, and the constant comparison, like that social media presents to everybody, but especially like children, teenagers, you know, there's that constant barrage of like comparison, you know, and that feeling, fear of missing out, just fear of like being able to keep up and be acceptable. So I think that places a huge amount of pressure.
I think there's a couple. I think that a lot of things we just didn't know what the diagnosis was. I mean, now that we have a lot more robust, whatever, DSM-4 or 5 to diagnose these, then people recognize them more. I mean, and I do think the expectations because of all that are higher. I think unfortunately too, you would think we have more ways to cope with problems, but just look at all the gun violence. That just, I don't know, that just saddens me. I mean, I think it's just because people are down and just don't know how to cope with the immense stressors of life. I mean, whether it's climate change or, I don't know, war. I mean,
I don't, well,
I mean, but that's some of the things I think about. But I do agree about the news. A lot more exposure to that.
yeah, it's interesting because it's not like this is the first time that we've experienced political divisiveness, war, natural disaster. I mean, those have been going on for millennia.
But it's not localized anymore. We're getting it from everywhere. And I think there's almost like a sense sometimes of, you know, helplessness that can also create, you know, feelings of anxiety and depression. I mean, learned helplessness is a real thing. And so when you're constantly being barraged by all of these problems that you can't necessarily do anything about other than your own, you know, attitude shifts or reframing or making sure that you're doing the best that you can do within your local sphere of influence. But that's, I don't know.
Yeah.
It's, you can't really prove it, but I definitely think there's that underlying.
I could see it increasing in adults. I am surprised that it's, and I could see it in children, but not elementary school children. But that's really a shame if now it's starting to influence young, really young children.
And it is. And it is. And it's not just the events of the world. You know, I'm just, you know, using anecdotal, you know, pieces when Lisa comes home and tells me about what's going on in the classroom, and you've got kids living in squalorless environment with a constant changing train of people coming in and moving out and living and not sure where they're going to be living next month. Kids that are living out of their cars and they're expected to continue to have the same level of academic performance as everybody else. And a lot of these kids are coming out of very, very challenging family environments that are not supportive and nurturing. I think that's an issue as well. So getting back to, but first of all, any other questions for Al, your comments that they want to raise on their talk? Because I got a couple other things I want to probe with you there. Other questions?
I just remember in residency, like our pharmacist that worked with us said fluoxetine was the preferred for kids and teens because it has a longer duration of action. So with kids being unreliable of taking medications around the same time, it kind of gives them better coverage if they miss a dose or so. So
That's a really good point. Thank you.
So I wanted to and just one is a comment and then another question. A few weeks ago, Dr. Andrus did her lecture on ketamine, and you know, within that commented on the use of ketamine for end of life depression, anxiety, and so I just wanted to make sure that was on the radar as well. And distantly related to that, in your research, did you find, you might have found it, or you might have seen it and didn't pull it out, but I'm curious what you found in terms of the use of psychedelics, hallucinogens, at addressing end of life anxiety, depression, existential distress.
I found quite a few articles that talked about it. I did not get into them because I had sort of resource overload anyway.
You bet.
So I kind of left them on the shelf, but there are a ton. If that's something you're interested in reading more about, there's a ton of like very, very new evidence for perhaps using some psychedelics at the end of life for treatment of symptoms. And then I also chose specifically not to mention ketamine because we had already had that lecture on ketamine,
Got
and
it.
also because it's it's still very early.
It is.
Yeah.
Yeah, no, absolutely. And one of the things I appreciated about your talk is that, you know, we certainly try to emphasize the importance within our specialty of evidence-based information, and you provided great evidence for everything you talked about. The other thing that we need to do is be kind of scratching into the new frontiers also. And as we, you know, one of the philosophies that I've carried into my practice in past years was the fact that we've got folks that are not going to be alive very much longer. And if there is an element of suffering that they're experiencing, we have an obligation to relieve that suffering. And yes, we go to the evidence that we have of things that can help to relieve it, but often they don't work. And if they're not working, I think we have an obligation to be creative in terms of looking at what is the genesis of their distress, of their symptoms, and how can we creatively identify opportunities to, you know, to address their distress at the origin. If we can identify that, and if we can't identify the origin, what are some opportunities that we would have that would create little harm, but have either theoretical or scientific basis for the possibility of working, and then on an individual one-on-one basis, help our patients through that particular process. Again, with the goal of relieving suffering when all else has failed. So, it's on the cusp. It's just outside of the cusp of evidence base, because just don't have that evidence. But we have a rationale for why. And I kind of come back to ketamine as an example. We have both anecdote and some scientific rationale as to why it ought to work. The fact that the double-blind, placebo-controlled crossover studies have not caught up with us yet. You know, the patient should not be held hostage by the trappings of our rigorous Western scientific methodology, if that makes sense.
They talk, I mean, I wasn't here, I don't know if I was here for that when they talk about nasal ketamine or IV ketamine. Both.
Oh, nasal, IV, sublingual, oral, take your pick. Even transdermal if you want, but takes a little longer to get it in. So.
Different availability depending on how you formulate it and who's compounding it, but especially in the inpatient setting, that's the thing that frustrates me with use of some of these medications, is that it just takes so long to finally start seeing some effect. And ketamine works, if it's going to work, it typically is much shorter before you start seeing some of those effects.
Yeah. Well, this is an excellent talk, Allie, and I appreciate you bringing this to us. It's something that's important that we hear every year. So I appreciate you doing that. Other comments or questions for Allie before we transition to our case? All right, then. Well, thank you all very much for attending, and we will see you all, or most of you, hopefully, on the 11th. I'm suspecting that our fellows, once graduated, will be long gone. You're still welcome to attend and to tune back in. Congratulations to you all. Well, you all hang on for the case presentation. The rest of you may leave, and we'll see you again.
Thank you.
Is this the last lecture before July? Or then like it
So-
starts July 11th? Or?
July 11th.
Okay. Sorry, I didn't know.
No, that's fine. Okay, Biancho, you have the floor for our final case presentation of the year.
Thank you. Can anyone hear me okay?
We can hear you just fine.
Perfect. So before I go into my case presentation, actually, first of all, really great lecture, Ali. Thank you for the lecture. And then when you talked about the dignity therapy and the legacy therapy, it kind of reminded me of one of the things that I wanted to talk about during my AI lecture. So if it's okay with everyone, can I share the video?
Sure.
So it's more of a like well, I would say it's AI, but also it's a technology. So in Korea, actually, this young girl passed from a blood-related disorder, and then her mother was grieving, so they actually created this daughter in like a 3D imaging, and then also created her personality and her voice and everything. So this is kind of controversial, and then it might be a little hard to watch. So I want to give you a heads up, but let's see.
7 years old, Nayeon died of leukemia in 2016. Her mom, Zhang Jisung, ran a blog to keep her memory alive. Zhang documented her memories with her daughter, posting photos of her, making her feel still alive somehow.
말을 한 거나. 손을 흔들고 어떤 미친 여자가 하늘에 손 흔들고 있을 저예요.
People kept saying to her that she should get over her loss and move on, but her grief was immeasurable, especially since the death was so sudden. The mother felt like she didn't have the chance to tell her daughter everything she wanted to. She badly wanted to see Nayeon in her dreams. Her blog was getting attention. The production team of the Moonhwa Broadcasting Corporation chose to cooperate with Zhang Jisung and offer her something unprecedented, a way to see her daughter again. To fulfill this grieving mother's wish, the production team turned to a Korean VR company, Vive Studio, that had recently won awards in a competition called VR Fest in Las Vegas. I thought the offer is something we should do, said the CEO of Vive Studio. The project could set a good example of how VR technology can connect with humans. And so, this never been done before concept was starting to be realized. By going over old photos and videos to extract expressions and body movements data and interviewing the family, the designers meticulously restored the appearance of Nayeon before she died, scanning a child approximately the same age and size and using an actress for animation. Getting the voice though was a bit of a challenge. Voice was trickier, but a company called NeoSapiens has artificial intelligence technology for voice recognition. But to use the technology, we should have a lot of recordings to be used as a basis. Since there are only a few voice recordings, about 1 minute, we found 5 children with similar voices and also recruited dozens of voice actors. Then we extracted the voices that had similarities. She also restored her favorite clothing that she used to wear and her favorite park and toys so that the mother could use the touch gloves to reach out and pick up items to interact with her. After 8 months, a crew of 15 people in Vive Studio completed the work. Finally, Miss Zhang could wear the VR helmet and touch gloves in the MBC studio and meet her daughter in the virtual world.
어땠어?
엄마. 엄마 어디 있었어?
엄마 항상
엄마 내 생각했어?
맨날
나는
해.
엄마 많이 보고 싶었어.
엄마도 너 보고 싶었어. 아니 잘 있었어?
나 예뻐? 예쁘지?
너무너무 예뻐 우리 나연이.
Zhang, equipped with the VR gear, continued to have a birthday party with Nayeon in the park in virtual reality. At the end, Zhang took off her VR helmet, overwhelmed with emotions. After the show aired, Zhang shared on her blog, Nayeon did not smile in my dreams. In my dreams, she always had a resentful gaze, perhaps due to my guilt. It was such great happiness to see Nayeon calling me with a smile. It was a dream that I always wanted to have. My lovely 3 children's laughter is filling Nayeon's empty spot a lot. Zhang wrote on her blog before taking it offline.
So yeah, that's I kind of wanted something that I wanted to share, and I was trying to find if there's like similar attempts made in the US, but I couldn't find anything. And then I
So,
think
yeah,
controversial.
I just, and just for those who want to do a little searching, I heard a promo just this morning driving in it was on NPR, and they were going to have a story later this morning about a guy who was in his 50s who was creating through AI a version of himself that would be able to help his wife after he died. And
Oh,
so I don't know any details. I don't know if that was the US or whatever, but I remember being in my mind, that's something that would be intriguing to look up.
mhm.
Yeah, you talk about that's taking that legacy therapy to the nth degree, quite
Mhm.
frankly.
Uh-huh.
But how fascinating.
Right. Okay, so I can now go into my case. So this is case about 63-year-old male, Vietnamese speaking only, and then his past medical history include non-small cell lung cancer diagnosed in 2023, so fairly recent. And then also he had a recent hospitalization with the Mycobacterium mucogenicum infection with pericardial effusion and renal failure requiring temporary hemodialysis. And then he recovered from that, discharged, but then this time he was admitted with the dyspnea, worsening generalized weakness, and left leg pain. So chest X-ray actually showed enlargement of the right lung mass, meaning the worsening of the cancer, and then also new complete opacification, which later was turned out to be pleural effusion. And then CT showed large bilateral lung mass, mediastinal adenopathy, metastatic adrenal nodules, and then also metastasis to posterior acetabulum, some more metastasis in the pelvis. And then because he was complaining of the left lower leg pain, or I left leg pain, so they did X-ray, which showed signs of metastatic disease in the left tibia. So yeah, he's just not in a good condition. So oncology, when they saw the patient in the hospital, because they patient was established with oncology outpatient, and then sorry. uh, yeah, so the cancer was progressing despite the chemotherapy and immunotherapy, and then oncology decided that there's no more treatment options that they can advise, and then hospice was considered to be appropriate at this stage. Pulmonology was also consulted. They offered palliative bronchoscopy in hopes to like placing an airway stent, and then they were able to do some debulking of the tumor around the trachea, but their left main stem bronchus was completely occluded by tumor, and then tumor was very friable, so they couldn't really do much otherwise the patient will bleed a lot. Oh, sorry. So we were consulted for goals of care conversation. So for the first visit, we actually had a joint visit with oncology PA. And then for better translation, we actually called and asked for in-person Vietnamese interpreter. And actually, wife was not present in the room and joined the conversation through phone. And then oncology PA actually explained that there were no more treatment options that they could offer. And then palliative team discussed like what can be done to make the patient comfortable. And then the patient's response was a little bit peculiar. So he simply said, okay, and not much else to many of the statements, including when oncology PA said, oh, there's not much option, there's nothing we can do anymore. He simply said, okay. And at one point, per interpreter, the patient said that he would let doctors do whatever that would help him, but it wasn't really clear if the patient is accepting that there's no more treatment options and he is okay with doctors going with the hospice, or patient is just not receiving or understanding the fact that there's nothing that can be done. And wife's response through the phone was kind of similar. She said okay and not much else. And then at the end or at the middle of the palliative goals of care conversation, actually her interpreter, the wife stated that she didn't want to talk about his end of life or his death anymore. So that was the end of the first visit. And the second visit actually was a joint meeting again with the oncology attending and PA, and also in-person interpreter, and then patient and his wife in person as well. So wife stated that she could not eat and sleep after the conversation the day before because she's so worried. And then the oncology attending again explained in detail that there were no more treatment options that can be offered or that would benefit the patient. And then the patient and wife seemed to understand when the oncologist was explaining all this stuff. But then after the oncology attending left, palliative team revisited the goals of care conversation. And then wife brought up a story of a relative who had similar symptoms and then actually received some kind of treatment that she does not well aware of. And then after that, her relative actually lived more than 10 years after that. And then she was asking for those treatments. And then after the oncology attending left, so we couldn't provide, well, we couldn't help with her regarding that much. So we actually had to repeat multiple times in different wordings and by phrasing it differently to tell them that there's nothing much we can do, and the cancer is just progressing with all the treatment that has been provided. And finally, the patient and wife agreed with hospice, but even at that time, we weren't quite sure if they fully accepted the fact that there's nothing that can be done, but they agreed with informational visit from the hospice. And then eventually they decided to go with the hospice. And last time I checked, the patient actually passed. So we did some debriefing because the case was a little, it's different from the usual case. So it seemed that the patient and wife had hard time accepting the fact that there were no more treatment options left, and also had hard time understanding the concept of hospice care or comfort-focused care. Because we had to explain multiple times, and even after that, I mean, it could be due to the language barrier, but also we weren't quite sure if they understood the concept of comfort-focused care. So we talked about this, and then we realized that the cultural background might have played a role. So this also comes from my own cultural background. So as you know, I'm from South Korea, and I spent most of my youth and most of my younger days in South Korea. I moved to actually Canada when I was in high school. So from what I remember, in South Korea, dying of cancer or disease is considered as failure. And it's considered as like a lack of effort or lack of trying if we if we were told that there's nothing that can be done or there's no more treatment. And this statistics kind of shows how South Koreans feel about death and dying and disease in general. So 76.2% of all deaths in South Korea in 2017 were in hospital. And because there's so much death in hospital, big hospitals in South Korea, they have their own funeral homes within their buildings. So like second floor or the basement floor, they have a funeral home ready so that when the patient passes in the hospital, the family can do a funeral a gathering at that place. And as you can see, also in 2019, 92% of cancer patients died in the hospital, which is a significant number. And then in 2019, they also did a study. Only 24% of all the cancer patients in South Korea utilized hospice service. And also that doesn't mean that they got out of the hospital, but they were just utilizing hospice service, whether they're at home or in the hospital. So some interesting facts. There is no Korean word that is equivalent to hospice. And I'm not sure that's the same for other East Asian countries like China, Japan, or Vietnam. And then talking about negative things, like the fact that there's no more available treatment, those are negative things, bad news. And then there's some superstition in East Asian culture that that may bring bad luck. Like I still remember when I was a young child, my family actually was going for a trip, and then my dad was driving, and I saw a car accident, and then I told my parents my concerns, like, what if that happens to us? And I remember being scolded by my parents that don't say such things like that. It's if you say things like that, it will really happen. So those are some of the superstitions in East Asian culture. And then also one of the things that is interesting that I found compared to Western culture is that East Asian countries, they are influenced by this Confucianism, which is kind of a philosophy created by Confucius, a person in China. And then one of the highly regarded virtues called filial piety, which includes duty to care for one's parents. So because of that, the traditional Korean sons and daughters may have like hard time processing bad prognosis of their parents, because bad prognosis means that they are failing their duty as a children to really take care of their patients. I mean, back in old Korea, that filial piety duty goes up to where the old Koreans will not cut their hair or cut their beard, because those are given from the parents, and they're so precious, so that they will not do anything to it. So these are some of the cultural backgrounds. And then, so what we thought about regarding this possible cultural background acting here, that maybe patient with East Asian background may have harder time processing a bad prognosis, because it's it's really a bad thing to them. And then, so other thing that we thought of was that if we suspect that there's some difficulty for patients and families in processing the bad prognosis, especially the traditional East Asian families, maybe giving them plenty of time to process. For example, we can give the bad news or bad prognosis today, and give them a day or two to really process them. And then the next day, we can talk about like goals of care, and talk about other options that can be provided from hospice. And we thought that might really help, and help them, or help the family and the patients to really understand and accept the bad prognosis. So my question is, if you have any experience with like different cultural backgrounds related to hospice and other comfort-focused care, and then if you also have any like suggestions or advice for this particular case. So I want to open the mic to the floor.
Hi, my name is Holly. I'm a nurse practitioner at Corwell East, Troy Beaumont. And we have a very high population of Arabic patients in the community. And our palliative team, we try really hard to make sure that we're speaking their language. We get an interpreter, but we also struggle with helping the community through the patients through their illness, because the Arabic community does not have a good interpretation for the word hospice in Arabic and Chaldean. So we try to spend a huge amount of time educating, but in the end, we also struggle with helping and supporting those patients and families, because the Chaldean community and Arabic community sometimes do not allow us to talk to the patients. The family wishes to shield them,
right?
Because their culture believes that we've been told that their culture believes that if you talk about the illness and acknowledge the illness, your illness will be amplified and you'll have more suffering. So, we appreciate this talk, because this really kind of hits home for us. So, we are open to any suggestions or recommendations that have helped others in the same situation.
Right. And thank you for sharing that, because that's also, I would say, common in South Korea, more older generation of South Koreans. And then, yeah, South Korean families, Well, the culture of South Korea, I think it's more of a collectivism instead of individualism. So family comes first, then family as a whole comes first other than individual. So yeah, when the patient is ill, then it's illness of all the family, and sometimes family shields the patient from the illness and they try to take care of that problem. So yeah, it has been it could have been challenging with East Asian communities as well, but thank you for sharing that.
Byung-Chul, could you back up one slide, please?
Sure. Which the
Nope, forward, the second to the last one. Go one more, there you go.
This one? Okay.
I like that second bullet. If you suspect difficulty for patients and families in processing the bad prognosis, give them plenty of time to process and approaching goals of care conversation gradually. And I would put one more word in there, repetitively.
Mm.
I think that these take time. I have a couple of things. First of all, I was really when you said that there really was no word for hospice in Korean, I was giving a presentation about 20 years ago down in Tegucigalpa, Honduras. It was a general healthcare quality lecture, so really didn't have anything to do with end of life care. And I was my slides were in Spanish. I don't speak Spanish, so I had an interpreter the entire time. It was about 2 days of speaking. Got to the end of the program and had a little extra time. So because of my interest in end of life care, I asked them how they approached hospice care there in Honduras. Just a general question. And it was the first time in 2 days that my translator stopped. And he said, "I don't know that word." And so I thought, these people, I'm ashamed at how I denigrated them based on my suspicion that they're, yes, I know that they're a developing country and they don't have these resources, but golly, they should at least know, hospice, right? And I was this is all going on in my mind. And again, I pretty much ashamed as how my mind took over. I like to think that I've matured some in the last 20 years. But so I explained to the translator, again, out loud in English, about, approaching end of life with dignity and relieving the symptoms and bringing a team-based approach to helping to comfort and relieve it. So he's taking all this information about what we do with hospice care and trying to synthesize that. And while he was doing that, a gentleman about 5 rows back stood up, who was obviously bilingual, and he said, why would we segment that out from the rest of the care? We do that for all of our patients.
Hmm.
And I was humbled.
Oh.
Because philosophically, that's what they were doing. They understood very early on that something is not when something was not curable. And it was just again reemphasized the importance of knowing where you are and who you're addressing. The other thought I had was that sometimes I thought that there were really 3 issues in terms of the challenges that you faced, and you had identified one of them beautifully, the cultural challenges there that can present themselves. I think that there's also some translational challenges as well. That sometimes, even though we have translators, sometimes our ability to communicate, especially the existential aspects of what we're trying to communicate, are very, very difficult through a translator. Because as you already pointed out in Korean, you don't necessarily have the words for that. So you're trying to cobble together an interpretation of what you mean. And a lot of times that becomes very concrete and leaving the emotional existential part out of that. And the third piece that struck me was that, even in our, West Michigan, predominantly Caucasian environment, we get families that act exactly the same way, that are reluctant to accept the diagnosis, that don't want us to talk to the family members about it, that really are having a hard time grappling with the reality of death. And that's why I wanted to bring that slide up. with that second bullet point. I think that regardless of the cultural and the language barriers that might exist, that is I think that's a great roadmap for dealing with any of that.
So this is Holly again. You know, those are so helpful to our palliative teams to kind of help gauge and drive the ship. Two things kind of came to mind when you were talking about it. So what I had a visit, and we use interpreters 100% of the time if we have a foreign language patient. So one of the meetings that I had with a patient's family, she spoke very good English, but I insisted we speak in Arabic, and my interpreter interpreted the word hospice as euthanasia. And
oh boy,
my family muted the conversation and said, "Do you know what they are saying?" And I said, I assume we're talking about hospice. She says, no, she specifically said killing the patient with medication.
Yeah, they wouldn't want that.
yeah.
So
You know,
that, go ahead.
That's really.
Yeah, that's and that I think relates to the problem of using intermediaries. Years ago, I was this is kind of a more meaningful moment, and again, a good learning one for me. It was a Spanish speaking patient, young woman that had very advanced cancer that had failed treatment, was in the hospital. They asked me to come in to help with the goals of care planning. We did have an interpreter. I had a medical student with me who had been with me for about three weeks. I didn't know that the medical student was fluent in Spanish. So I'm out in the hallway, and this is what I always do this with the interpreters, is to tell them what I want to do, what I'm hoping to accomplish. So they've got an idea what the goals are. So we walk in, we sit down at the room, and I go through my usual stuff. And I could just see that it's really not clicking with the patient and the family. They're pretty much stone-faced, they're gazing ahead, just much as you described in your case here. They're just not really seeming to respond. And I was, after about 10 minutes, I'm finding myself internally a little frustrated that I'm getting very little in terms of response back, both in terms of emotional, nonverbal, but also the verbal stuff. And I felt a hand on my shoulder. It was my medical student. And she said, "May I?" And I said, "Sure." I stepped aside, she sat down, grabbed this lady's hand, and in fluent Spanish went in there. Within a couple of minutes, tears are running down their face. And, you know, the family and the medical student is just, she's got such great command of what's going on. Of course, I have no idea what she's saying, what's going on there. And I lean over to the interpreter to whisper, to say, because I'm really in charge of this, you know, this relationship, right? And say, what is she saying? And she just said, "Shh, shh, this is really good." And so I took a back seat and realized, you know, that again, I mentioned earlier that sometimes when we're dealing with translators, you know, interpreters, it tends to be very concrete. And this person able to speak the language, I don't know that there's a substitution for that. And
Yeah.
I'm frustrated that as we live in and work in more, you know, cosmopolitan environments, we're going to get more and more of that. The other thing I want to just, Marisol also mentioned the same in Peru, no word for hospice. We have to keep in mind that the United States is pretty unusual in terms of this segmentation between palliative care and hospice. In most places in the world, it's just all the same. They use different words for it. They just typically don't use the word. They use the word palliative much more often than they use the word hospice. They don't have things like 6 months prognosis, and they don't, you know. But the concept of we've got something we can't fix, and we want to figure out how we're going to manage you in the midst of this, manage your loved one in the midst of this. That's ubiquitous. But the terminology we use, I think that's where we kind of need to kind of rethink our strategy sometime when dealing with cultural issues. And And I just would, Holly, you'd mentioned the challenge with the, with the interpreter that you had to make sure that you're doing a little prep work ahead of time. So they understand what we're trying to communicate.
Yeah, I appreciate that. One of the things that our team has helped to change the culture in our hospital, and our director is really kind of key on this too, is that we have changed the wording in our conversation when we feel that it's a challenge using that word hospice. We call it comfort care and comfort path. And so we only use those terms in that situation where we're having difficulty. The other aspect to it, and I apologize, I have to hop off, but there's a difference. So I had this situation with my own mother where she was dying of breast cancer, and religiously and spiritually, she did not want to accept the fact how ill she was, but she knew that, like, she had bone cancer from this breast issue. And in the very last days of her life, and she was unwilling to accept comfort care, I said to her, you don't have to accept the disease. You just have to accept the care that we need to help you with. And so I think there's a big difference between accepting and acknowledging, because some like in the Korean culture, it sounded as if accepting that was accepting you were a failure. So that goes to meeting the patient and family where they are, but it's so challenging. Like in my own family, I need to get you help so that you are suffering as you're dying, and I can't change that. And you don't have to accept it. You just have to agree that we can do the best care for you. So that piece has helped our hospital significantly in using that comfort care and approach to things. So I just wanted to share that. Thank you so much for letting me share.
Yeah, no, I really appreciate that perspective of you don't have to accept the diagnosis, but to accept the care. That's a really thoughtful, insightful approach. So
The only thing is Holly is that Holly? Are you still there? The only thing I'd add for that, particularly that culture,
Yes.
the Arab culture, is usually the eldest son is kind of the main, leader of the family. So if you can't explain it to the patient, maybe you can explain it to that person, and maybe that they can relay it. That might help a little bit. I mean, that's just a thought. I'm Arab myself, so, and I'm the eldest son.
there you go.
It's half Arab, but yeah, I know what it is. Yeah.
Other comments? We're at the top of the hour, and I thought we just ended our academic didactic year with a great lecture and a great case presentation. So thank you all. Congratulations to you as fellows for what you've learned, what you've contributed, and how you've grown. It's just been really exciting to see that, and just looking forward to seeing how your careers blossom in the years that follow. So thank you all, and we'll look forward to seeing those that are coming back in about 3 or 4 weeks. In the meantime, have a great rest of the month, and we'll see you soon.